Hi, everyone. Thank you so much for coming today and attending our final lecture in the MEDLAW learning series, When It Doesn't Necessarily Leave a Mark. There's been such a great month of wonderful speakers and participants, and so happy that everyone's been able to make it. I hope that you all learned a little something and can utilize that and bring it back to your courtroom practices. Today we have Dr. Stephen Messner, who's been instrumental in helping with this MEDLAW learning initiative. And he's going to speak on a very important topic today on abusive head trauma. I'm looking forward to hearing his talk. Tracy, I'll hand it over to you to introduce him.
Wonderful. Well, I don't know how he has the time, you guys, and I'm excited to hear his lecture as well. So I'm going to introduce him and turn it over because he has a lot to share and a lot to learn about today and learn from. So Dr. Stephen Messner is a board-certified child abuse pediatrician and the Pamela and Eugene A. Hayes III Endowed Chair for Child Protection at the Stephanie V. Blank Center for Safe and Healthy Children at Children's Healthcare of Atlanta. I do have to say we have one of the longest names known to man to read during a bio, but the Stephanie V. Blank Center for Safe and Healthy Children at Children's Healthcare of Atlanta. Prior to moving to Atlanta in 2007, Dr. Messner evaluated children for concerns of child abuse and neglect at the University of Florida for 3 years, where he was honored with the Florida Department of Health Leadership Award. He regularly lectures on the medical aspects of numerous child abuse topics and frequently testifies as an expert in the field of child abuse and neglect. His position at Children's Healthcare of Atlanta allows him to consult on patients who present to any of the 3 Children's Healthcare of Atlanta hospitals and to our clinic, the Stephanie V. Blank Center, supervise nurse practitioners, educate medical students, residents, and fellows, and also advise the hospital administration about matters pertinent to child protection. Dr. Stephen Messner sits on the advisory board of the Children's Advocacy Center of Georgia, Child Fatality Review Committees, and is a member of ABSAC and the Helfer Society. Dr. Messner served as a member of the executive committee for the American Academy of Pediatrics Council on Child Abuse and Neglect for 6 years and is the Associate Fellowship Director of the Child Abuse Pediatrics Fellowship at Emory University School of Medicine. Without further ado, and so much honor, I will let Dr. Messner take it away. He has a lot to share.
Thanks, Tracy. And thanks, Carly. I'm going to share my screen, and you guys can hear me okay. Find this again because it moved on me. All right. And I know you guys had the, if you attended some of the other lectures, you got to meet our second-year fellow, Keely Iannelli, and then you got to meet one of my colleagues, Dr. Verena Brown. So we are all physicians, but I thought I would just kind of like back up, and I double-checked that they didn't talk to you guys about this. I think, we're not all created equally, right? So we all do the 4 years of undergrad, graduate with, whatever degree. That could be like mine was in chemistry. My sister, who's a physician, she was a Spanish and physics major. But you have to, have some prerequisites for medical school. And then when you go to medical school, it's 4 years here in the U.S., different than like in Europe, where it's kind of all combined. And when you graduate from medical school, you either have an MD or a DO degree, just depending on which medical school you graduate from. And then you're a physician, but you're not really ready to go out and practice on anyone. So you have to do additional training in your specialty after that. So that's anywhere from 3 years for primary care. So like family practice pediatrics is a 3-year residency, up to like 7 years for some of the surgical residencies. And then that's typically when folks will go out and practice, either join a group or go out into practice on their own. Some folks will go on to do a fellowship. And so a fellowship is additional training after residency. It's not required. It is like if you see a cardiologist or a gastroenterologist, they've done internal medicine and then done a fellowship in GI or cardiology. We have them in pediatrics as well. And child abuse pediatrics is now a recognized subspecialty. It became a first boarded in 2009. And in order to sit for the boards now, you have to do a residency that's accredited and then complete an accredited fellowship. And there's 29 accredited programs in the US. We have one. I was the first fellowship director. Now I'm the associate fellowship director. Passed that baton a couple times. The other programs around here at UF and at Duke. And our areas of expertise are in child physical abuse, so all aspects of child physical abuse, child sexual abuse, the different forms of child neglect, medical child abuse, which is what we prefer to call Munchausen syndrome by proxy, because it puts the emphasis back on the abuse and that the caregiver is manipulating the medical system to abuse that child, and then psychological and emotional abuse. There are not very many of us. So there are only 361 board certified CAPS is what we like to call ourselves. And we have 5 here in Georgia. You've met 2 of us now, so Dr. Brown and myself. Dr. Iannelli is in training, so we have 2 fellows who are currently in training. The other 2 child abuse pediatricians here at Children's are Dr. Emmanuel Pena and then Dr. Tamika Bryant. And then down in Macon, there's Dr. Yamika Head. So that's all of us. Georgia, we're not very good. When you look at this heat map, when this looks at how many child abuse pediatricians there are compared to how many children there are in that state. You can see, like in Montana, there aren't any child abuse pediatricians, but we're really low when you look at the ratio of child abuse pediatricians to the population. So we're at 0.2. We're in I think we're ranked like at 40 something of the 52 states and territories that are ranked on this. Like Tracy mentioned, we are the Stephanie V. Blank Center for Safe and Healthy Children. We are a child advocacy center, and we're one of the 2 medical models in the state, the other one being down in Macon at Navicent, where Dr. Head is. So we're accredited by both the NCA and CACGA, and we have locations at Scottish Rite, it's across the street, which is where I'm physically sitting right now, and then one at Hugh Spalding. And we have a multidisciplinary team that is comprised of not just the medical team, but social workers, behavioral health, etc. When we see patients on the inpatient side of things, which is where we would be seeing children if we're going to make a diagnosis of abusive head trauma, it's going to be at either Scottish Rite, which is up here by the perimeter. Typically not at Hugh Spalding, because Hugh Spalding is actually the smallest freestanding children's hospital in the nation with only 24 beds, but we have a very busy emergency room. So sometimes children will present there with some type of trauma, then they'll get transferred out either to Scottish Rite, or it used to be Eggleston, but Eggleston is now closed. We now have the new Arthur M. Blank Hospital, which I'm sure for those of you right here in the metro, you've seen this being built, rising out of where our office park used to be on Tully Road. It's enormous. It's beautiful if you ever have a chance to go there. But they are the other trauma center. So this is the level 1 pediatric trauma center here in Georgia. So when kids present with abusive head trauma, typically they're going to be in some type of neurologically altered state, and they're going to wind up either at Scottish Rite or at the Arthur M. Blank Hospital. And what we're going to talk about today is abusive head trauma. Some of you may have heard this term shaken baby syndrome, and I just want to give you a little bit of context about that term. It was actually Dr. Caffey, who was a pediatrician, then did radiology. Back in the mid 40s, he described this. So this is, not something that's a relatively new diagnosis, where he was seeing patients and he's like, wow, I'm seeing this correlation where they have both head injury, so they have blood that's in the subdural space, that's that subdural hematoma, and I'll show you what that looks like and explain how you get that. And then fractures at the ends of their long bones. So the long bones are in the extremities, so in the arms and the legs. And then in 1971, Dr. Guth Klelch, he's a neurosurgeon, he proposed this mechanism about like how you could get this injury to the head as well as to the skeleton from one traumatic event. And he proposed this whiplash mechanism, that led to these subdurals, and that when Kathy was looking at the skeleton, he was like, well, there's these other skeletal injuries. So he kind of expanded that and said, okay, coined this term whiplash shaken infant syndrome. And that was in 1973. So we've kind of called it shaken baby syndrome ever since then, up until kind of recently in 2008. So there are organizations that you'll see this shaken baby syndrome maybe on their websites, like the CDC, AAP, although AAP has rebranded this. And then there's a center called the National Center on Shaken Baby Syndrome. And that's a really good resource. Their website is donotshake.org. And I have a couple slides in here with that link on there. But they have resources not just for medical providers, but also for folks who are, attorneys, lawyers, so judges, some for, the lay public, to just kind of increase their awareness of abusive head trauma, as well as it has a page where you can actually pull up some resources and a lot of the published literature on abusive head trauma. So it's a great resource that's, it's not password protected or anything. You can just click on that link and then kind of search around there. In 2008, the American Academy of Pediatrics changed the nomenclature for shaken baby syndrome. And the reason they did this, and closer to when this happened, I would get asked this a lot on the stand, like, oh, does this mean that, even the AAP, that they don't believe that you can shake a child and cause these injuries? That is totally false. The reason that they changed the nomenclature was to be more inclusive, so that it didn't just include shaking as a mechanism, but really looked at all forms of abusive injuries to the central nervous system. So that includes, the head, the contents of the head, the eyes, the neck, the spine. And it doesn't limit it to just shaking. We know that shaking can cause these injuries, but that is not the only way that you can get these injuries. You can have an impact. You could have a combination of shaking and impact. So we prefer to use the term abusive head trauma. And so you'll see that throughout the literature. This is the definition. It's inflicted, so it's not an accidental head trauma like such you might encounter from like a motor vehicle crash or a fall from a significant height. And it's to the cranium, the cerebrum, so the brain, spinal injuries that are either from blunt force trauma, shaking, or that combination of the forces. So again, it's more than just SBS or shaken baby syndrome. Shaken baby syndrome is a subset of abusive head trauma. Here's I put this in here just to kind of reiterate the epidemiology of abusive head trauma. This is from one of our colleagues up at CHOP, Cindy Christian's work, looking at the incidence in children less than 2 years of age, that it's about 17 per 100,000 person years, and that it's much greater in the first year of life, and the median being about 4 months of age. And this has been shown time and time again to be the most common cause of fatal maltreatment in children. This is from the National Center on Shaken Baby Syndrome. Here's that website I was mentioning before. It's don'tshake.org. I think I said do not shake, but it's don'tshake.org without any kind of like apostrophe. About 1,300 cases are reported annually. So we know that like all forms of child abuse, what's reported isn't always, reflective of the incidence, because we know that a lot of cases get unreported. So at least 1,300 cases that happen annually here in the US. About a quarter of the infants who are shaken will die from their injuries. About 80% of the survivors will have lifelong disabilities. This is the leading cause of child abuse deaths in the US, and shaking is the most commonly reported mechanism, although it's not the only mechanism. and it occurs most commonly in infants less than 6 months of age. Risk factors for abusive head trauma: if you have, just like in other forms of child physical abuse, family dysfunction, if there's mental health problems, stressors in the household, if you have parents with lower levels of education, although we've seen this in highly educated folks, you can't really rule out anyone from being a perpetrator in these cases. Having unrealistic expectations of the infants. We know that premature infants do have a higher rate of abusive head trauma than term infants, as do male infants for whatever reason. If there's prior physical abuse in another family member or a different child in that household, they're at higher risk. And then the number one cause that we see for triggers for abusive head trauma is that incessant crying. That's why there's a abusive head trauma prevention program out there that's called the Period of Purple Crying, which is to educate caregivers that it's okay to let your infant cry, that you don't need to pick them up if you're in a state where you may do something that is going to cause irreparable harm to the child. So that's the Period of Purple Crying. We have that in the nurseries and in the NICUs to educate caregivers about the risks of, if you're sleep deprived, you're at the end of your rope and you're hearing this child crying and you get up, you should not pick them up because we don't want you to do something that's harmful to the child. When we look at the injuries that we see in abusive head trauma, typically seeing blood that's in the subdural space, so that's what a subdural hematoma is, injury to the brain itself, and that's where we get the problems from abusive head trauma, where you have either bruising of the brain, tears of the brain, swelling of the brain, strain in the muscles in the cervical spine, bleeding in the back of the eyes, that's retinal hemorrhages, fractures of the ribs, and corner fractures. So just a little bit of anatomy here. Just want to show you where these different spaces are. So here's our little guy with the cutout of his skull. You can see going from top to bottom, you can see there's the scalp with the hair. That kind of spongy looking structure is the bone, that's the skull bone. And surrounding the bone is a membrane, that's the periosteum. And that we have on all of our bones. Then when you get inside the head, you can see at the bottom there, the kind of tannish structures, that's to represent the two hemispheres of the brain. So like what you typically picture, like think about Halloween or like what you've seen of a brain, those the two hemispheres. Our brain is also surrounded by membranes, and there's a membrane that's really tough. That's called the dura mater. That stands for tough mother. And that's kind of like a really firm membrane. And then there's one that's right on top of the brain, and that is the kind of lacy membrane, kind of like a spider web, and that's the arachnid membrane. So that's why it's called arachnid, is because it's like a spider web. When we talk about spaces, we talk about them being either above or below those membranes. So if it's below the membrane, we say it's sub, so like a submarine underwater. Subdural space is the space that's underneath the dura mater, underneath that thick membrane, the dura. But you also have a space underneath the arachnoid that's called the subarachnoid space. Normally, there's not anything in there. But if one of these vessels breaks, then the blood that's in the vessel can come out into that space and start filling it up. So what you're seeing here is a schematic of, this is the brain down here, the pink. And then you see the dura, and this blue vessel is a vein, so on the low pressure side of things. And it's coursing up from the brain, up back to the main draining vein, which is called a sinus in the head. And here it's broken, and you can see that there's the red here is the blood. So that is blood in the subdural space. So that's a subdural hematoma. This is what it looks like on a real brain. You can see this tannish membrane here at the top. You can see how it's folded over. That is that tough mother. That's the dura mater. And as it's folded back, then you're seeing underneath it. So what we're seeing here is actually all in the subdural space. And then these cortical veins, see these over here on the right, as they kind of go through that space, you can imagine that if they got torn, the blood would ooze out into this space, and that would cause a subdural hematoma. If it was below this kind of more shiny membrane here, that's the arachnoid membrane. If it's below that, then that's a subarachnoid hemorrhage, and it'll be right on top of the brain. And you can kind of see how they look different on imaging based on how they kind of follow the contours of the brain or not. And this is where that subdural membrane would be. When we see these in children, we always, like if you come in with a cough, you're not just going to walk in and the physician's going to say, hey, I know you have pneumonia. It could be a whole host of things. You could have like a lesion in your lung. You could have a viral, infection. You could have a bacterial infection. You could have fungal infection. You could have some, dysphagia that's going on there that's causing you to cough, or reflux. A whole list of things. We call that a differential diagnosis. This is the differential diagnosis for subdural hematomas. And you can see the first one here, just trauma. It can be any of these. It could be that it is abusive trauma, so abusive head trauma, but it could be accidental, or it could be from birth. It could be metabolic causes, infections, genetic syndrome. So we're looking for these things when we are evaluating children who have subdural hematomas. When we see a subdural hematoma in a setting of abusive head trauma, it's usually just kind of coating the brain. It's not pushing on the brain, causing any mass effect. We usually will see it on both sides of the brain. Usually see it on the undersurface of the brain, in between the two halves of the brain. That's called the interhemispheric groove. And it's a sign that the brain has rotated. And what happens is, as the brain, if it's rotating within the skull, you're getting tension on a lot of those bridging veins. And so multiple bridging veins are rupturing, and then the blood is oozing out, not just in one space. So that's how you wind up getting this classic picture in abusive head trauma for the subdural hematoma. Now, when the brain is being kind of subjected to these forces, it's not just causing injury to the blood vessels that course over the surface of the brain and back up to the sinus. The brain itself and the eyes, everything inside the head is being subjected to those forces. And we call those forces inertial forces when it's kind of changing directions, sort of like the infant brain is, I'm going to skip over to a slide here for my visual here. It's more like Jell-O than like a bowling ball, right? So if you think about the infant brain having Jell-O with chunks of fruit in it, kind of like like my mom used to make this, a fruit, a Jell-O mold with some like chunks of pineapple in it. If you move it, not forcefully, everything's going to move as a unit. But if you change direction rapidly, whether that be an acceleration, deceleration, and that could be changing direction or coming to a halt suddenly, or an angular rotational force on the Jell-O, the denser areas, so those chunks of pineapple, are going to kind of lag behind. And if there's enough force there, they're going to cause the Jell-O around it to tear. And the same thing happened to the brain itself. So that's when you wind up getting this axonal injury. So you get injury to the actual wires in the brain that are going out and sending the signal to the body. You get bleeding from those torn bridging veins, and this causes global effects to the infant. If there's a contact, so if there's like a slam either into something or by something, you get those contact forces. You may or may not see a skull fracture. You may or may not see swelling on the scalp, where you actually have bleeding that's underneath the scalp, outside of the skull. Those subdural hematomas or subarachnoid hematomas. But what you can also get is actual contusion or bruising to the neurons that you can see on imaging to the brain. So that's all what can happen initially. Then when you have an injured brain, you can get what's called secondary brain injury. And we do everything we can to try and minimize this injury to the brain, but sometimes it will occur, and it can occur, and this is typically when there's a fatality, it's because of the secondary brain injury. what happens is when you injure the brain, you're not able to send the signal out to your diaphragm, which is your breathing muscle, and you wind up having either stop breathing, which is what we call apnea, or you have dyslabored breathing, so it's kind of like disorganized. And what happens is you wind up getting really hypoxic environment where your levels of oxygen in your blood are dropping and dropping, and so then your brain isn't being bathed in a good amount of oxygen. We can also see that the vessels can kind of like spasm down, and then it kind of cuts off the blood supply to the brain. That's what's called ischemia. You can't differentiate those two things on imaging. You have the same end effect, so we call it hypoxic ischemic injury. So that's very bad for your brain. Also, having low blood pressure as a result of the brain injury, that's bad because then you have this ischemia that's happening. Sometimes we'll see babies who will be having a prolonged seizure, and so that's increasing the metabolic activity of the brain, and so it actually will go through and use up all of its stores of energy quicker, and then you wind up getting more injury to the brain. So that's the secondary brain injury. The way that we look for these things are on two different imaging modalities. One is called a CT scan, which is computed tomography. It's actually just x-rays, but we do through planes instead of just a plain film. They're very quick. We can pick up things like recent blood. We can pick up that there's damage to the brain, and we can detect that there's fractures to bones when we're looking at the head. An MRI is a better study, but we're typically not getting that first because we don't have them in the emergency room, and they take a lot longer. They're not x-rays. It actually uses a magnet, so there's no radiation. And with this, we can better characterize where that blood is within the skull. Is it in the subarachnoid space? Is it in the subdural space? And we can look at the brain itself much better to see if there's injury to the brain. We can see that if there's shearing to the brain. We can see if there's those types of contusions to the brain. We can also sometimes see if there's bleeding in the back of the eyes on the MRI. This is what an MR scanner looks like. You can't go in there with any metal because of the magnet. When we do the imaging here at Children's, we will do a specific protocol that has been designed by our neuroradiologists to look for these shear injuries, which will help us to detect if there's been these inertial forces on the brain itself. We will also image the neck and all the way down through the spine, really looking for any kind of injury that can occur throughout the entire central nervous system. One thing that's pretty neat that we can pick up is if one of those bridging veins ruptures and then it forms a clot, it'll show up on the MRI as a lollipop or a tadpole sign. So this is a little schematic from one of the papers where they were doing this study. This up here is the main draining vein, and then this is that bridging vein, and this is that it ruptured. So there's blood that kind of started oozing out into the subdural space. And then when it clots, it forms this larger clot. There were two groups of researchers working on this. One thought it looked like a lollipop, one thought it looked like a tadpole. So you'll hear both. This is what it looks like on MR. So you'll see, I think it looks more like a tadpole, but you'll see these collections of congealed blood in the subdural space, and that is a telltale sign that you've had trauma. So this will differentiate it from some type of like spontaneous, like one of the glutaric acidurias or something else that would potentially cause on our differential blood being in that subdural space. We know that this is a traumatic cause because we can see that bridging vein has clotted off. When we look in the cervical spine, that just means in the neck. If there's this whiplash type component to the abusive head trauma, we will be able to pick that up sometimes on imaging. So this is an example of a patient we saw here where you're actually seeing blood that's down here in the epidural space, which is outside of the head, but down here in the upper or lower cervical and upper thoracic spine. And then here you're seeing all of this blood and injury to the little ligaments that hold our spine in place. Those are the interspinous ligaments. So we're able to pick that up on the MRI. I mentioned that you can get bleeding in the back of the eyes. This is just an example of what the inside of our eyeballs look like. They're filled up with a clear fluid called the vitreous, and it's pretty sticky. But this retina is what kind of lines the back of the eye and comes all the way out here to the front, right before the iris, and that's called the ora serrata. When you look at the retina, it's this over here at B is a cross-section of that retina. And you see that there's all these blood vessels that run through this. So it's kind of like a lasagna. And if there's enough of this inertial force, rotational force on the head, it's going to include the eyes. And that fluid that's filling up the eyes is kind of sticky, and it can pull on those layers of the retina. And when they pull apart, they bleed because of all these blood vessels that are coursing through there. And so what you wind up getting are retinal hemorrhages. The way to diagnose these is we will have the ophthalmologist come and look through a dilated pupil and look to the back of the eye. They're looking for accumulations of blood in the different layers of the eye. So they'll say that they're subretinal, intraretinal, or preretinal. And it's caused by that, what we call vitreoretinal traction. So it's the tugging of the vitreous fluid on the retina. And sometimes we can see them on the MRI. Not all abusive head trauma patients will have these, but about 2/3 will have what we characterize as too numerous to count. So there's a ton of them, that they're in all of those layers, and it goes all the way out to that ora serrata. But about 15% will have no retinal hemorrhages. It doesn't mean that they're not a victim of abusive head trauma. So this is how they do it. The ophthalmologists do the indirect ophthalmoscope. They will look with this magnifier. They're looking with a headlamp. And this is a normal retina here. You're seeing where the optic nerve comes in and bumps into the back of the eye. And all of these vessels, these are all normal. They course through with the optic nerve to the eye. Again, here's that optic disc, all the blood vessels normal. All of these blops of blood here are retinal hemorrhages. So this is abnormal, and this is as a result of trauma to the eye. This is different than just seeing a couple, because this sometimes will come up, oh, this patient got CPR. You can see a couple of them, but it's very different. Not all retinal hemorrhages are the same flavor. So if we're going to say that it's significant for trauma, especially in the setting of abusive head trauma, we're going to be looking for it being too numerous to count or greater than 10, multi-layered, and going all the way up to the ora serrata. And that's this part of the retina right here, the ora serrata. Sometimes we can see it on the MRI. This should not be here on the eyeball. You can see this collection of blood in the retina, as you can see here. So we're actually doing some studies now where we're looking at the sequences of these patients, the MRI, but we're including the whole optic nerve sheath, because what you'll see at autopsy is oftentimes you'll see bleeding in the optic nerve sheath, and that's not something that you can see from a dilated eye exam. So moving outside of the head, the other injuries that we see are fractures, commonly in abusive head trauma, and those are fractures of the long bone, so the arms and the legs, at the weak point, so at the metaphyses, the growth plates. And those fractures are called bucket handle fractures or corner fractures or classic metaphyseal lesions. And then occasionally we'll see rib fractures, posteriorly meaning on the back, or laterally meaning on the sides. So a classic metaphyseal lesion, which is also known as a bucket handle fracture or corner fracture, has a very high predictive value for being abused in a child less than 1 year of age, whether or not it's in the setting of abusive head trauma or not. The reason that it's the most frequent fracture type that you see in fatal child abuse is because we see this most often associated with abusive head trauma. So they're dying from the head injury, but we see these other injuries as a result of those forces being applied to the body. And what's happening is those arms and legs are kind of flailing back and forth, and the forces are concentrated at the joints. So you wind up getting the soft tissues are stronger than that growth plate, and it can pull that part of the bone off. You can also see this if that arm or leg was just like yanked by the perpetrator. This is what it looks like on X-ray. It looks like the corner is cut off. Here it is at the wrist. Sometimes it'll look like this, like a line. So the bones are white, air is black, and you shouldn't have this black line going across this tibia here proximally. This little cartoon shows where it's fractured. And some folks felt that that looked like a bucket handle. So that's why it's called a bucket handle fracture. It's the exact same fracture. It's just that you're looking at it from a different way. And then you can also see rib fractures, a fracture type that is very rare to be caused by accidental trauma in a child. So like just a kid falling down, very rare that they're going to get a rib fracture because you need to have a compressive force about the chest. So it's less than 1% of accidental fractures that we see in children. Usually, if we're picking this up without any kind of trauma history, it's found incidentally, like on a chest x-ray because we were doing a chest x-ray for another reason, like looking for a swallowed coin or for a pneumonia. Sometimes the caregivers will report feeling a pop, but that's the exception rather than the rule. We usually don't see this from birth trauma, though it can occur, but very rare from birth trauma, rarely from CPR. If it is from CPR, it's usually on the front. If we see children less than 3 years of age who have a rib fracture, it has a 95% predictive value that it's abusive rather than it was an accidental rib fracture. And usually they are on the back or on the sides. We know that the more rib fractures you see, the higher the risk of death. And typically these kids are not going to have any nearby bruising. We see it on the x-ray. We know that it's recent, yet it's less than 10% of these kids will have nearby bruising. And that's because the way that you're getting these fractures is that it's a squeezing force that's applied over a longer period of time, as opposed to a blunt force impact, which will cause the bruising, cause those blood vessels to rupture. This is a schematic of, this is a chest. Here you're seeing they're on their back. This is the vertebral body. This is posterior, where the thumb is anterior, and then on the side is lateral. And the kind of grayed out is the chest at rest, and then you can see this is a hand squeezing that infant. Typically, when people pick children up, they're facing whoever's picking them up, so the fingertips are at the back, and the thumbs are at the front. So if you squeeze, see if you're pulling with your fingertips forward, it's going to cause those posterior rib fractures. This is what it looks like on a plain film. So you're seeing these big balls of callus. These are healing posterior rib fractures. Here's on a CT scan where you can see this posterior rib fracture that's acute, having no signs of healing, and this lateral one that has a big lump of callus on it. So we know that that one's at least 7 to 10, maybe 14 days at most old to get that that callus. So we know that this child was injured on at least 2 separate occasions. This is an example of a child who we saw here. If we see, if we have a chest CT that shows this rib fracture on it, what we'll do is get a 3D reconstruction of it. And so here it's a lot easier to see. You can see all of these lateral rib fractures that have callus on them. So we try to get these, if we have the study, we'll do these 3D reconstructions because it's easier for the non-medical folks like a jury or a judge to actually visualize where those injuries are as opposed to on the plain non-3D rendered CT scans. So how do you get this all from shaking? Because the infant's neck is relatively unstable, the head is really much heavier in proportion to the body weight than in adults. So it's a 25% of the body weight as opposed to 10%. And so that allows the head to kind of really be subjected to these forces because the infant can't hold their head steady and it's not being supported during that repetitive shaking motion or from a slamming motion. You get that tearing of the bridging veins from those acceleration, deceleration, or rotational forces, the traction in the back of the eyes to cause the retinal hemorrhages, those corner fractures at the weak points on the arms and legs, and then compressive force on the chest, causing the ribs to break if there's enough force on the torso. This is a little, just a little computer animation of where the injuries are occurring. So this is showing an infant. You can see that the head was kind of moving back and forth during that shaking motion. This is to explain where the anatomy is. So inside the skull, here you're seeing the dura mater is that gray membrane. And then this is going to show the circulatory system of the brain. So here's your brain with those cortical veins that are on the surface of the brain. You see the superior sagittal sinus that's running down through the center of in between the two hemispheres. And there's that subdural space, so below the dura, but outside of the brain. And here's our bridging veins. Now, when the infant is subjected to those forces, so the acceleration, deceleration forces, you can cause these injuries to the brain. This is showing the circulation of the blood from the veins back up to the sinus, and then it goes back down. This is supposed to demonstrate that the central nervous system gets both signals from sensation, so that the body is feeling the grasp, the ball in its hand, then also sending out action signals to the muscles, so the muscles of the hand to hold on to the ball. Here it's sending action signals out to the diaphragm, which is the breathing muscle, telling it to contract and then to relax, which is what causes us to breathe and fill up our lungs with air. Now, when you have a shaking scenario, you can see that the brain will start to rotate within the skull. And what this is trying to demonstrate is that the bridging veins, when they're stretched, that they wind up ripping, and you can wind up having blood in that subdural space. That's what this is supposed to show, the blood oozing out there. Now, that typically doesn't cause any problems to the infant. It's not the presence of the blood there. That's more of an indicator that the brain has rotated within the skull. Where you get the problems are from the injuries to the brain itself. This is showing that blood accumulating in the back of the eyes in the retina, so the retinal hemorrhages. Now, the yellow here are the axons. So this is showing like the wiring of the brain. And just like those bridging veins become ruptured, here from the axonal trauma, you can wind up having trauma to the axons. And what happens is then the action signals from the brain are interrupted. So you wind up not having good connection from the brain to the infant's body. So that includes your skeletal muscles. So what we'll hear from folks is that these infants go limp, or they become like a noodle, or like a dish rag, is what I often hear from caregivers. So that's an indication that you have that brain injury. The other thing that we hear is that the children will go from breathing and being normal with their breathing to then either having gasping breaths, they're kind of grunting. I've heard folks describe it as that, or that they stop breathing altogether. This is showing where the posterior rib fractures come from. So from those fingertip pressure over the back side of the ribs as they're holding the infant and pulling forward, causing those ribs to bend until they can't anymore, and then they wind up fracturing. And that's how you get those posterior rib fractures. So I think this is a good demonstrable aid to use if there are any investigators on, or any attorneys who want access to this. Just let me know, because it was part of an online textbook that I don't believe that it's currently available. So what comes up is this question of like, how much force is there that we need to cause these injuries to this baby? Because we know that it's not a trivial force. Normal handling of a baby is not going to cause these injuries, or our emergency rooms would be filled with babies who have these types of injuries, or we would have died out as a species, eons ago. So It's more force than a reasonable adult would use when handling a child. Say that if someone saw this, they would recognize that this was a violent act towards this child, and this is not a trivial force. This is not just like picking the child up, even tossing them in the air. This is not a short fall, so like dropping a child from, 4 or 5 feet. We see that all the time. You would not get these kind of injuries to the child's, the infant's brain that would cause these type of, outward signs that we're seeing. So there's not a great model yet to accurately replicate this in the lab. There are some computer models that are getting better. We know that no one would scientifically line up, a bunch of kids and shake them at different amounts of force. So this is where the controversy has come up in court. It's not controversial at all in the medical community. So just want to kind of like put this in context, like the bumblebee. So back in the 30s, there was this French entomologist, this Agnes Magnon, and he did all these calculations, and he said he was sitting around with his physicist friends, and they were looking at the bumblebee, and they were like, well, this thing's got a big body and these little tiny wings, and they did tons and tons of calculations, and they determined that it's impossible for this bumblebee to fly, based on its weight, the size of its body, its little tiny wings. It couldn't be done. And it took up until 2005 with high-speed photography that they were able to prove in a model that the bumblebee was able to fly, even though we all knew that it's able to fly, right? And it was because they were able to see that they had it wrong. They assumed that the bumblebee's wings were flapping up and down, when in fact they're actually kind of like flapping back and forth and making these little tornadoes underneath their wings to keep the bumblebee in the air. So, just because you don't have the model doesn't mean that it doesn't occur. So what happens, what we hear a lot in court is that you can't shake an infant hard enough to cause all of this damage, which is not true. That the force necessary would cause the neck to fail. That was based on some literature. I haven't heard that recently, but that's been disproven. All the calculations in that study that showed the threshold for causing tissue injury to the brain, far exceeded the tissue strength in the neck. Therefore, to injure the brain, you'd have to have failure of the neck. That's been disproven. That infant brains are just prone to bleed, or that the vessels in the eyes are just fragile and bleed easily. This is not true. So the controversy really comes up in court. So you guys will hear this. We're seeing it more and more in the media, and especially in social media. Just like with the bumblebee, I think that seeing something can really tell you a lot about the matter at hand, as opposed to like coming up with a model. So the confession literature is really, I feel, the best model that we have right now. We know that these confessors may minimize, but at this point, they usually don't have anything to lose. These are studies that have been done on folks who have confessed either to, it was witness, they confessed to a medical provider or to law enforcement, or after they've gone through the court system and were found guilty, then they confessed. This is an old article, but I just used this to just kind of demonstrate this and contrast it to a newer article. This is from the 90s, where they looked at hundreds of head injured cases. They found about 450 that were abusive head trauma, 171 where they could figure out who the alleged perpetrator was, and then 81 of those cases where someone confessed. So, a pretty high percentage, which is pretty remarkable. I haven't had that many confessions in my career of 20 plus years. But they had these 81 perpetrators who confessed. All of them had bleeding in the around the brain. About over a third had retinal hemorrhages. 15% had other abuse-related injuries. About 20% died. 70% impaired, and about 10% were normal. So they looked at the profiles of these perpetrators. Not unsurprising, about over half were the father, and then about 16% unrelated male, so mom's boyfriend. About 15% were the mother, so you can't rule anybody out, right? 5% the babysitter. And interestingly, when they looked at who admitted to it, the folks who were related to the victim were much more likely to confess to it. And the thought was that they, had this, more of a bond to that infant. So they were much more likely to confess because of the guilt. So the babysitter's far less likely to admit than the parents. And the perpetrators, what they noted was that these patients became limp, they started seizing, they were throwing up, they were very lethargic, or they stopped breathing. And when medical providers saw them, they noted that they were either seizing or they were very lethargic. If you look at the groups, this was early on when we were looking at shaking or shaking versus impact, before we ever had the term abusive head trauma. And you can see here that perpetrators admitted to just impact alone versus shaking alone. You can see that both groups had subdural hematomas in them. They had retinal hemorrhages. So you can absolutely get this from shaking alone without having the impact. And in about 57, in 57 of those cases, they were able to determine when the patient became symptomatic. And 52 of those 57, they said it appeared immediately after the abuse. So that's why when we speak with the investigators, we always ask them to try and find out, when did this baby go from being normal to abnormal? What can we try and help to pinpoint whose care this child was in when they became symptomatic? Because it's very difficult to time it based on just the imaging alone. So we really need to look at the history of what that baby was acting like. Sometimes we'll hear, oh, this baby, fell off of a couch or fell off of a bed. So that's what we call the short fall defense. We know that, kids fall off of these low elevated surfaces very frequently. Usually, if this is going to be the defense, they will offer this article, a Plunkett article, which is an old article that looked at Consumer Product Safety Commission data. Look, they only saw 18 falls that resulted in death over an 11-year period. Most of these kids were outside of the age range of who we're typically seeing in abusive head trauma cases, so the relevancy isn't always there. But when you look at these cases, they weren't just typical short falls. It was a kid who was on a porch swing with a caregiver and they fell together, or they fell off of a ladder. So you have to really make sure that we're comparing things apples to apples, as opposed to trying to infer from this study that, shortfalls can cause, these kind of injuries. This article by Chadwick was great. So they did the study and they looked at, kids having shortfalls. And they said it's not zero, but it's incredibly rare. So it's less than 1 per million. They looked at toddlers having ground level falls very frequently, 4 times a day. From low elevated surfaces about 1 time every other day, and that infants, so that's our age group, will have low elevated surface falls about 4 to 5 times in the first year of life. And so this is a very frequent thing that we see with infants, yet we're not seeing this high rate of fatalities from these kind of trivial impacts. Other proposed mechanisms that come up in court is that, oh, there was a big clot that happen in that main draining vein. So the blood vessels that are the cortical veins that are going back, the bridging veins, they're hitting this roadblock. And so the pressure builds up and then they just explode, and that causes a subdural hematoma. We will look for that on our MRIs. And we know that that doesn't cause injury to the brain if there was this blood clot. That it's because of the hypoxic ischemic injury, so kind of changing the cause and effect. We know that you get hypoxic ischemic injury from the brain injury itself, but saying that the brain injury is caused by that hypoxic ischemic injury, or that it's from a spinal tap, or that it's because the infant was choking, or that it was the baby had some bleeding, which we know that babies can't get blood in the subdural space from birth trauma, but that, weeks to months later, then suddenly this baby became symptomatic and it presented at that time remote from birth. So there's actually a good consensus statement on abusive head trauma that came out in 2018, and they specifically talk about those things. So this is the link to this. I can get this to you. It was published by our radiology colleagues. and they said there's no reliable medical evidence that the following processes are causative in the constellation of injuries that we see in abusive head trauma. And it's all of those things that I just mentioned to you. The thrombus, so that clot, the hypoxic ischemic injury, the lumbar puncture or a spinal tap, or that choking. And that you're not going to see something, remote from the time of birth that's going to suddenly rear its head. So the other thing that's in that consensus statement is that abusive head trauma is a medical conclusion. It's not a legal determination. I get defense attorneys trying to paint me into this corner all the time that I'm saying, who did this, the intent of this, and that is not what abusive head trauma is. It's a medical conclusion. It is not saying what the intent of the perpetrator was, and it's not diagnosing a murder. That's, in the courtroom. So, it's really difficult to get folks to kind of get on board and have a consensus statement. Initially, they got 9 other endorsements. So this is the Pediatric Radiology Society, the European one, 9. So that's remarkable. But then in 2019, even more joined. So it was up to 15. So this is widely accepted by lots of groups, not just pediatricians and not just child abuse pediatricians. They published the impact of this this consensus statement on abusive head trauma in 2021. They said that it helped to educate a diverse stakeholders. It was the most, downloaded, top 5% of all research ever tracked by this. Number 1 from the Pediatric Radiology Journal, tracked by this all metric. So it just shows that folks are paying attention to this. And the current list of endorsements is 17. So to have someone, on the stand try to paint this picture that this is a fringe theory, or that this is just, one person's hypothesis or an opinion about the constellation of injuries that we see in abusive head trauma is just really false. So I just want to make sure that that's very clear. This is widely accepted throughout the medical community, throughout the globe. And this more recent confession, this is a review article from 2020, where they looked back on papers that were published from the 60s to 2018, lots of confessions, 434. You can see that it's both shaking and impact alone, shaking plus impact, and the majority were males. So very similar to those earlier studies that I showed you. And they showed that there was no statistical significance in the percentage of confessions when they reported just shaking alone. When you looked at different continents, so this is globally, when you looked at the circumstances where they confessed, whether it was just to a medical provider or to the police, or it was through the court system. So their conclusions were that shaking is still the most common mechanism that's reported, and that confessions reveal striking similarities in the mechanism of abusive head trauma occurring across the globe. Then I wanted to quickly touch on Daubert hearings. These are coming up more and more frequently here in Georgia, and it's very useful to keep unscientific testimony out of the courtroom. I've been asked to testify in these frequently. They're based on the reliability and the relevance. And I want to make sure that everyone knows, in the setting of abusive head trauma, that Dr. Narang, who is also an attorney, he published 2 papers. It's over 250 pages, so I'm not going to go through the details of this, but it walks through a Daubert analysis specific to abusive head trauma. So I think it's very important that if you're having a Daubert hearing on abusive head trauma, to know that this exists, and that you can look through this, because it pretty much goes through, with a fine-tooth comb, all of the elements of the Daubert analysis for abusive head trauma, and shows that this does hold up to the scientific rigors that are necessary for saying that this is a valid diagnosis in the courtroom. So in summary, remember that we won't be able to diagnose abusive head trauma if we're not looking for it. We need to correlate the injury with whatever mechanism they're saying happened, so we don't do this in a vacuum. It's recognized by numerous reputable organizations. It's not controversial in the medical community. The consensus statement is endorsed by 17 global communities, and confessions reveal that shaking is the most common, but there are other mechanisms that can cause abusive head trauma. And don't forget that just because we don't have a model yet, that it doesn't exist. So thank you. I know I went a minute over. If there are any, I'm going to unshare my screen so hopefully I can see what's going on in the chat. Mainly want, I see a question here about can't rule out children based on strength. Yeah, so if the proposal is that like a sibling, like a toddler, like a elementary school age child cause these injuries, no, they don't have the strength to cause this. Now, if it's like an adolescent, sure, they do have the strength to cause these kind of injuries. Yeah, I see this. Yeah, frequently that a sibling. What we see with injuries from siblings is, did they try to put them onto an elevated surface, like, or take them down from the bed and then they fall, or they're carrying them and drop them from a short height. You can get impact injuries from that, but you don't get that severe injury that we see from abusive head trauma, where you actually get the axonal injury, the injury to the brain itself. Any other questions? I don't want to keep you guys. I was trying to squeeze everything in there. It's a very complex topic, but I want to make sure that folks kind of understand, at a kind of high level, but then how it pertains to the courtroom, and knowing that I already sent Angie the two Narang articles, so the Daubert analyses for abusive head trauma, because I think that those are great ones to have, and then I can also send along the consensus statement.
Yeah, Dr. Messner, and I'll remind Angie that you sent those to her. And then also, I noticed somebody mentioned don'tshake.org. That's a great resource too. And that also talks about the period of purple crying. If you're, in the market of trying to help caregivers or the community understand the dangers of shaking a child or navigating your own emotions before acting when you have such small children in your care, that's also there too, and on that website, so don'tshake.org. But yeah, and if you are having any issues getting those resources, if they don't come through a follow-up email, feel free to email us at cpctraining@choa.org, and I'll make sure to get it to you guys. So that way, Dr. Messner, you don't have to navigate emails. I know you get a lot on your hands.
I appreciate that.
So that cpctraining@choa.org is in the chat, but that is a lot to cover. I don't know how you do that every time. I'm always like mesmerized how you cover so much in such little time and do it so efficiently.
That was really a great lecture. Kind of context, how this happens, and then what people might encounter as they're handling these cases. So, and also I saw that these are recorded, and so we're gonna see about how we can post these, get it out to everyone.
Great.
Yeah.
Well, thanks for organizing all of this.
Yeah.
Great. I hope it was useful. And we did this one on a Friday, knowing that we wanted to try this to get this all done in the month of June, because the next one would have been July 3rd, right? So I appreciate you all joining on a Friday. Thank you. Thank you.
Yes, and thank you so much for coming to the whole series. We're planning to do more of these, so we'll get these out to you as we continue in the next month or year or so. And then also we'll be gathering all the CLE and submitting that next week. So if you don't hear from that by next week, then let us know. And then if anyone wants to chat or connect or anything about this initiative or other topics that could be of interest, we'd love to do that. Again, I'm Carly Oakson, and thank you so much for attending. And thank you for such a wonderful lecture. Bye, everyone. Have a great weekend.
Thank you, guys.